In this lesson, we will explore cerebral circulation, the blood supply to the lobes of the brain that we have studied in this chapter. Throughout the brain, blood vessels supply tissue with oxygen and glucose. There are 4 vessels which provide primary circulation to the brain: the 2 vertebral arteries, which join to form the basilar artery, and 2 internal carotid arteries. We typically define intracranial circulation as being anterior and posterior. Anterior circulation supplies the hemispheres and subcortical tissues as well as the basal ganglia. On the other hand, the posterior circulation supplies the brainstem and cerebellum. Let's take a closer look at the anterior circulation. Circulation to the cerebrum arises from anterior blood vessels, which are derived from the internal carotid arteries. The internal carotid arteries branch to form the middle cerebral artery and circle of Willis, with anterior and posterior communicating arteries connecting to the anterior and posterior cerebral arteries, respectively. There are specific regions defined by the anterior, middle, and posterior cerebral arteries in the anterior circulation. The anterior cerebral artery supplies primarily the mesial portion of each hemisphere, including the paracentral lobule of the motor cortex. The motor neurons of the paracentral lobule provide motor output for the lower extremities. Recall that the motor homunculus has its feet and legs hanging into the midline between the 2 hemispheres. By comparison, the middle cerebral artery supplies the outer or lateral surface of the cerebral hemisphere. These areas include the primary motor and sensory cortices, the motor and sensory association areas, the optic radiations into the temporal and parietal lobes, the frontal eye fields, and the speech and language areas of Broca and Wernicke. Included then are regions of the frontal, temporal, and parietal lobes. The posterior cerebral artery provides supply to the occipital and temporal lobes, which encompass the visual and auditory cortices. While the region of distribution of each major artery in the anterior circulation is well defined, their actual region of distribution abut adjoining vessel territories. In this cross-sectional view of the brain, the anterior cerebral artery territories are labeled in red, the middle cerebral artery in yellow, and the posterior cerebral in green. Regions of overlap create what are known as border zones or watershed regions. You can see the border zone or watershed region illustrated here between the distribution of these 3 major vessels. Because these border zones represent the furthest reaching regions covered by each artery, when there is low flow and decreased blood pressure, the border zones are most susceptible to infarct. When these regions become ischemic, they produce what is known as watershed infarction. This type of infarct occurs most frequently when there is unrecognized carotid artery disease and some incident provoking low blood pressure. In some cases, particularly when there is slow onset of either intracranial vessel disease or carotid stenotic worsening, anastomotic blood flow develops between border zone regions, altering the normal supply. Thus, when there is acute ischemia, there may be slow flow through these anastomotic connections, leading to the development of something called the ischemic penumbra. This is tissue in danger of permanent damage, but which has not yet infarcted. This tissue sparing, albeit only short-lived, allows for successful TPA treatment or interventional neuroradiologic thrombectomy with good recoveries. Now that you're familiar with the anterior circulation, let's take a brief look at the consequences of anterior circulation strokes. The anterior cerebral artery territory syndrome consists of sensory motor deficits. The motor function of the contralateral foot is affected predominantly, with much less weakness in the shoulder or arm noticeable. Sensory abnormalities are mostly discriminative in nature. The head and eyes look toward the stroke. There is usually rigidity. By comparison, the middle cerebral artery stroke syndrome consists of contralateral hemiplegia, arm and face greater than leg, hemianesthesia, and homonymous hemianopia. There is usually deviation of the eyes toward the lesion side. In cortical stroke, the signs of neuropsychiatric phenomena help to differentiate weakness and sensory change seen with subcortical strokes or lacunar disease. Neuropsychiatric symptoms differ depending on the hemisphere which is involved, but are always present in cortical stroke. In the dominant hemisphere, which in 90% of the population is on the left side, the patient exhibits aphasia because of damage to Broca's area and/or Wernicke's area. Broca's aphasia presents as non-fluent speech with poor prosody and consists of mostly nouns and verbs. Wernicke's aphasia produces an abnormal pattern where fluidity of speech is maintained, but the words are non-contextual and resemble a word salad. There is no obvious meaning to the sentences spoken. Alternatively, with an infarct of the non-dominant right hemisphere, the patient instead will exhibit agnosia, lack of ability to recognize objects, and neglect. Posterior cerebral artery stroke will affect the occipital lobe, producing defects in the optic radiations and the calcarine or visual cortex. Thus, the visual fields are affected, producing a homonymous hemianopsia. Although we have been talking about the cerebral hemispheres, I want to briefly discuss the posterior circulation and subcortical stroke syndromes here while we're discussing the cerebral circulation in general. The posterior circulation, once again, provides blood flow to the brainstem and cerebellum and ends in the circle of Willis, providing circulation to the posterior cerebral arteries. The brainstem is densely packed with tracts that pass from the spinal cord to the brain and vice versa. Also, nuclei and axons of the cranial nerves are present here, and damage can lead to a different host of signs and symptoms. Stroke affecting the posterior circulation will cause symptoms bilaterally in the body, which are often crossed, meaning that there may be motor and sensory signs on opposite sides of the body. Frequently, there is severe headache, vomiting and nausea, vertigo, nystagmus, weakness, extraocular movement abnormalities, and ataxia. The consequence of these complaints by the patient are what are known as the D symptoms. These include dizziness, dysarthria, disequilibrium or dystaxia, deafness, diplopia, dysphagia, and dysphonia. Subcortical stroke refers to smaller infarcts or strokes in the deeper brain tissues. Pathologically, they appear as pools or holes in the brain tissue, leading to the term lacuna, which is Latin for pool or pit. Most often, they occur in the basal ganglia, thalamus, pons, and the subcortical white matter. There are 5 lacunar stroke syndromes, the first 3 of which are self-explanatory. These include pure motor stroke, pure sensory stroke, and mixed motor and sensory strokes. A fourth is called dysarthria clumsy hand syndrome, where the affected patient has garbled speech and ataxia of the upper limb, which they interpret as weakness. They are not weak, but rather have coordination issues, and this can be brought out on examination. The fifth syndrome, ataxia with crural paresis, involves weakness of the leg and ataxia of the upper body.